Welcome to the Brilliant Board Review Podcast, your trusted source for high-yield board prep, CME, and the latest in clinical medicine.
Now, let's talk about DOACs. We know they've been evolutionary, revolutionary, and they make life a lot easier. Just think about them whenever you have a patient with warfarin and having to make sure that you're getting those numbers right. Now, are DOACs perfect? No. Do they help out a lot? Yes, and they make life a little bit easier for all of us. And they also help patients out. But let's try to identify when are DOACs preferred and when we should be thinking about it and when should we stop them. Now, conditions for when DOACs are preferred: venous thromboembolism. Now, atrial fibrillation, excluding the patients with mechanical heart valves or rheumatic atrial fibrillation. Now, if you notice and you're looking at your cardiology friends' notes, when you look at, they're talking about, a lot of times they'll put an atrial fibrillation and put non-rheumatic. The purpose of this is the treatment plan is going to be different. So that's why they do that. You may always wonder why they may say rheumatic or non-rheumatic atrial fibrillation in their notes. Now, when are DOACs a no-go? When should we never use them? This is due to our current evidence. Mechanical heart valves, never use them, warfarin. Rheumatic atrial fibrillation, warfarin. That's why when you look at those cardiology notes, they put rheumatic versus non-rheumatic. It helps you in the treatment plan. Thrombotic antiphospholipid syndrome, you're going to use warfarin. Now, transcatheter aortic valve replacement, use antiplatelet therapy. Embolic stroke of undetermined source, antiplatelet therapy. Now, we have a full lecture on DOACs if you choose to go through it. It's in our Brilliant Board Prep. It's very helpful, and it's most up to date with all the latest information on DOACs, because DOACs are newer in the scene, and there's still a lot of information, still a lot of studies to be done on them. Now, when is it on cert? And this isn't saying that you shouldn't use them, but maybe this is a shared decision-making. Pregnancy, no great studies right now. End-stage renal disease, the reason why this is here, and this is changing, it's a shared decision-making. Well, this was because the studies excluded end-stage renal disease. Now, are people with end-stage renal disease on DOACs and doing well? Yes, there are. So this becomes a shared decision-making. Same thing with these is there's not great studies and needs to have continued workup. And these are complexities. When you look at these have a lot of complexities to them, and we need to figure out why they're having them. And it's almost a shared decision-making, maybe also with expert decision-making too, is left ventricle thrombus, catheter-associated deep thrombosis, splanchnic vein thrombosis, and cerebral venous thrombosis. These ones would need more of a discussion. It also needs shared decision-making with the person who's receiving these, the patient themselves, or the patient's power of attorney, or the person that they're using to trust to make their decisions for them, because there's not slam dunks either way on the decision-making for these.
Thanks for listening. Visit brilliantcourses.com to learn more and claim credits for this educational activity. See you next time.